So it's my great pleasure to introduce Dr. Katherine Keyes, who's professor of epidemiology at Columbia University Mailman School of Public Health. Her research focuses on psychiatric and substance use epidemiology across the life course, including the early origins of child and adult health and cross-generational cohort effects on substance use, mental health, injury outcomes, and suicide and overdose. So thank you, Katherine.
Thanks so much for the invitation to talk today. Thanks everyone for coming in person and everyone online. I'm going to kick things off today talking about social media restrictions. Is that an intervention that we should consider to prevent adolescent depression? And I'm going to go through this in a number of different steps. I'm going to start by talking about the current policy landscape around social media and youth, and specifically honing in on how elected officials are discussing in publications the connection between social media and youth depression. I'll then take a relatively short deep dive into the actual research. Is the actual research that's being done matching what elected officials are saying is the justification for social media policies? And then discuss how we move forward. So probably people are familiar with the Surgeon General's advisory that was published last year on social media and youth mental health, and it's a really interesting document to dig into because what it covers is not only the evidence that's available, but the evidence that's not available. And the Surgeon General really advocated, the precautionary principle that we're all familiar with in public health, that our children and adolescents don't have the luxury of waiting years until we know the full extent of social media's impact, which makes sense. And the policy landscape around social media has really been ramping up. There are at least 30 states with pending legislation related to social media use by minors in 2004, and over 50 bills have already been passed. And my colleagues and I at Columbia University have been kind of finding different schemas to organize these different laws. So you can organize the different policies related to social media use and youth mental health into policies that pose restrictions on the platforms versus those that pose restrictions on the users of those platforms. Then there are policies that directly relate to social media use and those that indirectly relate to social media use. So something like having an age verification requirement would be a restriction on the platform that would directly relate to social media use, whereas something like banning smartphones in schools would be something that is a restriction on the user of social media and indirectly relates because the whole phone is banned and not just the device itself. So what my colleagues and I then did is do a deep dive into Google News, and we extracted 637 documents where an elected official in one of these states that has passed a social media restriction has discussed the evidence base underlying the reason for that passage. And from those 637 documents, we identified 161 that met our inclusion criteria. And we extracted themes from those. And there's a whole range of different topics that elected officials are talking about. I'll focus here on statements that relate to mental health, and I've highlighted a few of them here. So for example, an elected official said that the internet and social media have been proven to damage mental health. Another elected official said, the program will address the symptoms of youth mental illness as well as one of its largest causes, screen addiction and social media. Another example is social media is a product that is shown to increase depression, loneliness, and anxiety. So those are just 3 examples of the many different types of statements that elected officials are making to the public about the state of the evidence that's underlying their rationale. So I think the question for us as epidemiologists is kind of moving beyond what the elected officials say to ask whether the evidence base underlying those statements is supportive of the conclusions that elected officials are drawing. And there's no absence of evidence in this space. This is just a few of the many systematic reviews, meta-analyses of meta-analyses that relate to social media youth and youth depression. I couldn't even fit them all in one slide, so here's another slide with more systematic reviews and meta-analyses, and this isn't even all of them. Perhaps one of the most recent systematic meta-analyses that was published was last year in Nature, an umbrella review of the benefits and risks associated with youth interaction with electronic screens. This was harmonized effects from 102 meta-analyses that themselves comprised over 2,000 underlying studies that had almost 2 million adolescent data points contributing to them. And there's a whole range of different findings in this paper. I really suggest people look at it, but I'll focus here on specifically the harmonized meta-analytic effect of social media on depression among adolescents using observational data. And the correlation between time spent on social media and youth depressive symptoms is about 0.12, statistically significant, etc. And this is really consistent with all of the other meta-analyses that you'll find in the literature. Generally, most reviews and meta-analyses report that the correlation between time spent and adolescent depression is somewhere between 0.1 and 0.15. This is fairly well accepted at this point. Then what you'll typically see is scholars getting into a really long debate about whether 0.12 is meaningful, how much variance is explained, is that a big effect or a small effect, etc. But as an epidemiologist, to me, this is really beside the point because there are so many broader issues with this literature that we need to contend with before we even start discussing whether a 0.12 is meaningful. So I'll share today a few of my biggest gripes. This is a real small one, but there's not a linear relationship between time spent on social media and youth well-being. This is a meta-analysis that was published in 2015, almost 10 years ago. And what you consistently see is a J-shaped curve, where the students with the lowest depressive symptoms are those that are using screen time in moderate amounts or social media in moderate amounts, usually somewhere about 1.5 to 2 hours a day. And then you see this kind of escalating arm thereafter as the time spent on screens or social media gets into the 3, 4, and 5 hour range. And what we're really concerned with, right, is the length of this arm over here. And when you start digging into the kids who are using screens and social media at that level, and you analyze it longitudinally, that 0.12 starts to go down quite rapidly. So for example, this is the Heifer longitudinal analysis, which you'll see frequently cited, but this again is emblematic of a lot of the longitudinal research in this area, that actually when you analyze, you break down kids who are using social media at one time point and their depressive symptoms at the next time point versus kids who are depressed and the change in their social media use. You find the strongest signal for kids who are depressed changing their social media use at later time points. So for example, no significant associations between social media use and later depression, but a strong signal for depression and social media use thereafter. We found a similar effect in the ABCD data, which is a large pediatric neuroimaging data set of almost 10,000 kids. And what we focused on, we looked at every single diagnosis that you can make in the ABCD data, but I'll point you here to depressive symptoms. We looked at kids who had borderline or clinical depressive symptoms and how they changed their social media use at the next measurement time point. And focusing on these blue dots here, essentially what we found is that kids who have depressive symptoms tend to escalate their non-social screen use and non-social social media use, scrolling, clicking, not interacting with others at later time points. Kids with depression tend to decrease social screen time use, the amount of time they're interacting with other people. And you'll see this really consistently in the literature too, which begs the question, why are we looking at time spent on social media when actually the activities that you're engaging in social media are a much better marker for engagement? And that's really consistent now with communications literature and trust and safety literature, where there's now accumulating evidence that the associations with well-being and mental health differ by device. Are you using a smartphone, a tablet, a desktop computer? What type of application are you using? Is it social media or is it email? What brand of application are you using? Facebook, Instagram, WhatsApp, TikTok, etc. What feature are you using? Are you doing status updates, profile updates, Messenger? And then what type of interactions are you having in those social media spaces? These are the relevant constructs that we need to be talking about and not time spent on social media, which is too crude of a proxy to really draw any kind of causal conclusion. So then you might think, well, we can experimentally manipulate this, right? We can do randomized clinical trials where we randomize people to using social media or not using less social media or more. And in fact, there have been 27 of such studies that have been meta-analyzed. This was a pre-registered meta-analysis that came out last year from Ferguson with 27 different experiments where people were randomized to use less social media. And the meta-analytic result was null. If you combine all those 27 studies, you see no effect. Now, there was a lot of debate about this meta-analysis when it came out because the follow-up times are really variable. You'll assign someone to not check Instagram and then measure their mental health a week later using relatively crude measures. That's not really informative. Some of the follow-up times are 1 week, 2 weeks. Very few of them are long-term, and they don't address the central question that we're interested in is what would these kids' mental health have been if they never used social media, right? It's not really generalizing to the broader construct that we want to look at. Now, in epidemiology, people have been advancing more quasi-experimental and instrumental variable approaches. So, for example, this paper just came out a few months ago and took advantage of the fact that in Japan during the pandemic, there was huge demand and shortages of PS5s and Nintendo Switches. So there was actually a lottery where kids could get a PS5 or a Nintendo Switch. And so they actually used that lottery assignment and followed those kids up and assessed their psychological distress and their well-being. And actually what they found is that the kids who got their PS5s and Nintendo Switches sooner had lower psychological distress and better life satisfaction than the kids who had to wait to get their PS5s and Nintendo Switches. We've done similar instrumental variable approaches in the ABCD data. This is with my colleague Tim Brown, who's an economist at Berkeley, using leave one out peer effects, where essentially we look at the level of social media use in the geographic area where a kid lives and leave out that focal child from our assessment. And what we find is that if you just do a straight observational analysis, for example, you get a null result for a change in a focal child's social media time spent on social media use and their subsequent suicidal behavior. But when you use an instrumental variable approach with the leave one out peer effects, we find, similar to the Japan study, that increases in social media use decrease suicidal behavior in the ABCD study data kids. And then the last thing I'll just point out, kind of going back to that meta-analysis of 102 meta-analyses that was just published a couple months ago, that if you look, they show in that paper the whole range of different correlations and effect estimates for all kinds of different outcomes. And actually, when you look at social media effects on risk-taking, substance use, risky sexual behavior, the meta-analyzed correlations are way higher than the meta-analyzed correlations between social media use and youth depression. But we're not talking about those. And actually, if you look at general internet use, which no one is suggesting you restrict kids to use, that effect size is almost twice what the effect size is for social media use and depression. So, in conclusion, my take on this literature is that we actually really don't know. Social media use may be causally related to adolescent depression, but we are not designing or conducting the studies that we would need to form conclusions that are relevant to guiding policy. We've collected data on almost 2 million adolescents, but the state of the literature is that we're not conducting studies that are capable of answering questions about the causal role of social media in youth mental health. So where do we go from here, right? Obviously, one solution is designing better studies. We are epidemiologists. This is what we do for a living. This is actually our job, is to informing people about how to design studies that are more rigorous than most of the research that's out there. But I would actually point to literature where there is overwhelming evidence of causality to drive policy. And I'll give you a few examples. This just came out last month in The Lancet. It's the new Lancet Commission on Self-Harm, which is an exhaustive review of the evidence for different policies that can reduce suicidal behavior and youth mental health. And what do they point to? Tackling poverty, means restrictions, and societal drivers of misery that can reduce suicide rates. This evidence is overwhelming, causal, and can be used to inform government policy in relation to self-harm. They also do tackle social media and internet use, but from an online safety component. We know that kids who are experiencing mental health crises, especially suicidal crises, are using the internet in dangerous ways that fuel additional self-harm. Currently, over 3/4 of adolescents who survive a serious suicide attempt learned how to die from an internet site. So those are actual harms that are going on right now that we can take action to prevent. And finally, I would just point to James Kirkbride's analysis in World Psychiatry from last year. This, again, is an exhaustive, systematic review of literature on social determinants of mental health and disorder. And the key determinants are things that we know well: maltreatment and neglect, household dysfunction, economic hardship, parental mental health, racism, structural discrimination, and other social determinants of health. We have causal evidence that these are deterministic of mental health outcomes. So as we're discussing social media restrictions, putting them in the context of the social determinants of health that we have decades of research to support is, I think, an important area moving forward. I would just like to acknowledge my funders and thank you for inviting me today.